Today we're going to talk about transitional care planning. I hope you guys can hear me. There's a little echo in the room. Please make sure you watch the entire video because I'm going to be saying some code words throughout the video, and you will have to email those to me later on today. And that's how I will know that you have watched this video. So you can't skip through it. You'll have to watch the entire video. So let's go ahead and get started. All right, so transitional care planning. This includes changes and transitions that are often difficult at any age, but even more so for individuals who are frail, ill, elderly, or vulnerable. So when we're talking about transitions, we are referring to maybe an older adult who was in the hospital and maybe they're not healthy enough to go back home at this point, but they're healthy enough to leave the hospital. And so in that case, they may have to transition to a different level of care. And transitional care planning refers to services provided by social workers to help those patients and their families cope with their transition and understand the services available. They also facilitate the transfer and help the patient and the families access benefits to help with the cost of care. So an interprofessional care coordination. So in the past, we've talked about an interdisciplinary team, and I reminded you guys that this is simply a collaboration between the social worker, dietary, rehab, activities, nursing. Everybody comes together to create a good plan of care for each patient, and each plan of care is unique to the patient. So an interprofessional team is a multidisciplinary group of healthcare professionals who collaborate together to coordinate and deliver care to common group patients. It's the collaborative effort between the professionals and the patients to develop common goals, and they regularly share information. They monitor the carrying out of care plans, and they evaluate the outcomes of their interventions. And there are some benefits to approaching healthcare in this way, and those include increased access to healthcare, improved outcomes for individuals with chronic diseases, better use of clinical resources, improved recruitment and retention of healthcare providers, and decreased tension and conflict among caregivers. So these are just some of the benefits to employing an interprofessional care coordination. So for social workers, how do we prepare our social workers, so you guys, to collaborate with these other professionals? And so a lot of schools of social works have begun to partner with nursing programs and public health to design learning experiences and curricula that include interprofessional education. And training in these programs, they seek to instill 4 main competencies. And so those include, they'll help you work with individuals of other professions. You'll use your knowledge appropriately to assess and address healthcare needs of patients. You'll be able to communicate effectively with patients, families, and communities and other health professionals. And you apply the relationship building values and principles to the team dynamic. So building a good rapport with your other interprofessional team members. So at this point, I'm going to give you the first code word. The first code word is green. Right. Transitional care planning through continuum care. Individuals move up and down through various levels of care, but it's not necessarily in a linear fashion. So for example, if an individual were to go to the hospital and they're discharged home, maybe they'll get home and realize they need a little bit more help than just, say, in-home care can provide. And so then they'll go to a different level of care if that's the case. So failure to provide for a smooth patient transition following discharge from an acute care hospital can result in unplanned readmissions, which we don't want, falls, medication problems, and poor compliance and follow-up care. So the discharge process. As a social worker, in any type of healthcare setting, you'll often be in charge of carrying out a discharge plan. And a rule of thumb that was always taught to me was that discharge starts upon admission. So when a patient or a resident is admitted into your facility, when they come in, you already know what their discharge plans are. So for example, me in a long-term care setting, before the patient hit the front doors of our facility, I knew if they had planned on staying at our facility long-term, or if they were there for a short-term rehab stay, or if they planned on going to our assisted living level of care, all of that. So that's a good rule of thumb. If you know those things before the person gets there, then it makes the discharge planning process a lot smoother. But to do a good discharge planning process, the social worker will determine the current status, resources, needs, preferences, and limitations of the patient and his or her family or caregivers. You'll establish an initial discharge plan. Now remember, just because the initial discharge plan is to go back home, that can change in the middle of their stay. They may, decline a little bit and need to stay a little bit longer. So that's why it's referred to as an initial discharge plan. You'll actively prepare and educate the patient and family for the return home. And you'll implement services and assess the transition back to the community following the acute hospital stay. So transitioning home. Home healthcare services represent an important post-discharge intervention for patients with additional medical needs that continue following hospitalization. So home healthcare is just exactly what it sounds like. It's healthcare services that are provided to you inside of the home. And so it's split into two levels: skilled home care and basic and personal assistance. And approximately 12 million individuals receive home health care services from nearly 33,000 providers because of illness, disability, and terminal care, and that's each year. All right, so to be considered for home health care, you can't just, be just healthy physically and mentally and expect home health care to come into your home and just help you because you don't want to do it. You have to present as unsafe or physically taxing for you to leave your home. You must require the physical assistance of another person and or specialized transportation services to leave your home. At this point, I'm going to give you the second code word. It's blue. All right, so home health aides. These are the aides that are often employed at home health companies, and they provide assistance with bathing and dressing, and they can help with light meal prep and housekeeping. So like homemaker services is something that we refer to those things as. To assist patients in accessing home healthcare services, a social worker might, number one, determine if the patient is now receiving or has previously received those services. And so what that means is let's say the patient in the past, they have used ABC Home Health Care, just in general. That may not be a real home health care company, but ABC Home Health Care. Your goal as a social worker, if they had no problems or if they have no issues with using the ABC Home Health Care, to make sure that the transition and there's a smooth transition and a continuum of care, you would want to use that same company since they provided services to the individual in the past. So if the services met the patient's needs and consent is obtained from the patient, services should be coordinated with the pre-existing agency to ensure continuity of care. It's a good rule of thumb. Let's say if this person has never had home health care services and we're just going from blank. You rely on a maintained list of acceptable providers, and it's important to avoid conflicts of interest. So it's important to avoid telling Miss Brown or whoever that, well, I think you should use this home health care company because they help most of our clients or our residents here at our facility. It's good to avoid that because at that point, you're encouraging them and you're swaying their decision when the decision should be theirs. So the best thing to do is get them a list of possible home health care providers and let them choose. I usually say, here's a list. I want you to go home, do some research, where I'll tell the families that, or I'll tell the resident to go back to their room and do some research, and you let me know which one you like and we'll get you set up. Individuals who qualify for Medicaid may They may be eligible for other services, so chore and companion services, that'll help them remain in their home. Services may vary by state, and they may be referred to as chore grants, chore services, or adult home help services. Service help, they help patients with activities of daily living. So we often refer to those as ADLs, and they include eating, bathing, toileting, transferring, and meal prep. Waiver programs also provide extensive services and supports in order to allow individuals to remain in their home, and it's available in some states. Okay, so durable medical equipment, you'll hear that a lot. We refer to it, we use the acronym DME, stands for durable medical equipment. And normally when someone's getting ready to go home and maybe you're gonna set up home health services, the physician will write an order for durable medical equipment. And so this is where social workers pretty much collaborate extensively with rehab. So durable medical equipment includes wheelchairs, walkers, bedside commodes, and other type of adaptive devices that can help the patient's mobility and function. You know, in the end, the overall goal is to have a smooth transition back home or wherever the previous level of the previous residence was. And so typically the physical therapist will recommend equipment to help with the patient's mobility, and the occupational therapist will recommend equipment to help with ADL, such as bathing and toileting. So transitioning into the extended care facility. Extended care facilities, these are kind of what you guys have heard of before, I'm sure. So nursing homes, but it's important to remember that a nursing home, most nursing homes, also, they not only offer long-term care stays, but they also offer short-term. And so your short-term is called skilled care, and it's provision of physical therapy and nursing services, and it's usually covered by Medicare. Basic care is just routine. This is what you think of when you think of a nursing home, custodial care, and it's paid for privately by Medicaid or by a nursing home insurance. Approximately 50% of residents are over 85. Health conditions impair the residents' ability to perform their ADLs. More than 50% are incontinent, meaning they have no control over their bowel or bladder. 50 to 70% are affected by dementia. Risk factors for admission include older age, low income, poor family support, low activity level, and cognitive and mental disorders. So I always talk to you guys about self-determination. And so this gets really tricky when you, especially in a long-term care setting, self-determination and preserving autonomy for the client. And so it's important for the patients to be engaged in the decision-making process as much as their physical and cognitive capacities permit. So in the event that you have a patient who you think may not be cognitively competent, it's important to have a psychiatric evaluation done to evaluate competency. And if they're not competency, to pursue legal guardianship if cognitive impairments are severe. And so if the patient is competent to make decisions, he or her has the right to refuse placement. So if you need to, you're trying to have them placed somewhere, or you're trying to encourage them or find them somewhere to be placed, they can refuse it, and there's nothing you can do because they're in their right mind and they have that right. And so social workers have an important role to play in helping individuals and families select nursing home care. And so that's part of the discharge planning process based on what healthcare setting you may be working in. So the Omnibus Reconciliation Act of 1987, we refer to it as OBRA. It's additional screening that may be necessary to ensure the patient is not inappropriately institutionalized. And so what this does, and we have a screenshot of what that paperwork looks like. This is called a level 1 screening. And so what happens before an individual is placed in a nursing home for short or long term, this paperwork has to be done by most of the time it's the hospital social worker. So the hospital social worker complete this, and it asks a lot of things. So down here you'll see, does the individual have a current, suspected, or history of major mental illness? And you have to check one of these. If they do, and so what that does is, what happens is when you fill it out, you submit it, and then the state gives you a response. And so if this person's good to go and a nursing home is a good level of care for them and they won't be in an environment where they're a threat to themselves or others, then it'll come back good. But if not, if it triggers, is what we call it triggering, it'll come back and it'll say that it requires a level 2 screening. And what that means is somebody from the state office will come out to your building and they will, or to your hospital, wherever you are, and they will actually do a physical screening of the resident or the patient to make sure that they're appropriate for whatever placement you're trying to pursue for them.